It's a great honor to be here in Medellin at the 25th meeting of the Pan American Trauma Society. It's really been remarkable for me being involved with the society for so many years. I'd like to thank Dr. Maria Jimenez and Carlos Morales and the organizing committee for really working so hard and putting together a wonderful meeting for all of us. I also need to give due credit to Dr. Avitori, Dr. Abatanos, and Gladys Shanklin. You've heard all the work that they've put into this society since they've taken over the leadership. And again, thank you to our dear friends for taking such good care of the society. There are so many people that I need to thank in this organization, so many dear friends. We have more than 20 past presidents, but I think two people need special mention for me and for the society. First is, if you will, the godfather of the society, Dr. Aurelio Rodriguez, who got me involved in this society many years ago, and I thank him. And also Dr. Juan Carlos Piana, my dear friend, my partner, the president of the society, and again, the Department of Surgery and myself personally, we're very proud of him and what he's done for the society. It's a great honor to give this lecture today. I want to talk about the spleen and the state of the art over the next 25 minutes. And there are certain key principles as we begin this talk. These are sort of the ground rules of what we're talking about today, that unstable patients require immediate operation, and generally these patients need to have a splenectomy. Non-operative management is an option only in stable patients, and that may seem like a rhetorical statement, but we'll talk about the fact that we don't really practice this the way that we should. It's rare that we get to perform splenography for blunt trauma because most of those patients with minor injuries are now managed non-operatively. And I think it is important that no patient should ever die from a splenic injury that we've treated non-operatively, because it's one of the few things in trauma where the solution is very simple. You take the spleen out, you solve the problem. So as we talk about non-operative management, I think it is an absolute that no patient should die as this approach is implemented. Now, for many years, we really didn't understand the spleen, and the mantra was successfully observed, and then the group that failed, observation. And again, since these are all adults, there's no difference in age, but what I want you to focus on, because this will be important later, is the group that went directly to the OR had the lowest blood pressure, the highest injury severity score, and you see the ISS was 32 direct to the OR, 20 in the patients who were observed successfully, and then 27 in patients who failed observation. In a later study, this will be identical data 10 years later. This shows the initial management schema by grade, and you see grade 1 through 5, planned non-operative management in green, so you see the low-grade injuries were usually admitted for observation. As you go toward higher grades, that was really not an option, where 75% of grade 4 and 97% of grade 5 patients went immediately to the operating room. And that, again, is relatively consistent data. So when we talk about non-operative management, we're really talking about lower grade injuries. And the opportunity to do that in high-grade injuries is actually relatively uncommon. If you look at failure rate by grade, you see that it's 5% for grade 1, 10% for grade 2, 20% for grade 3, 33% for grade 4, and 75% for grade 5. But again, realize this is 3 out of 4 patients, and the other 74 patients have already undergone splenectomy. So 98% of patients with grade 5 injuries underwent splenectomy. So I would suggest that non-operative management in that population with grade 5 injuries is not a good idea. And this just shows what I mentioned, that grade 1 and 2, and to some degree 3, the success rate of non-operative management is high, but 80% of grade 4 injuries and 98% of grade 5 injuries either underwent immediate splenectomy or late splenectomy when they failed observation. This shows the degree of hemoperitoneum by grade, with green small hemoperitoneum, brown moderate hemoperitoneum, and orange large hemoperitoneum, showing success rate of non-operative management. And what you see within each grade as you have more and more blood, the chance of non-operative management decreases. So what we learned from this study is that patients who need immediate operation for splenic injury are hemodynamically unstable. They have high-grade splenic injuries. They have multiple injuries with high injury severity score, and larger hemoperitoneum predicts failure of observation. However, the patients who do fail, 2/3 fail in the first 24 hours. So it suggested that we mistriaged these patients, and they should have gone to the operating room sooner. So the next study was to look at these patients who failed non-operative management, and there were 97 patients who were admitted and failed observation, and we looked at the pre-hospital records and hospital charts on all these patients from all 27 trauma centers. And one of the things that was important is to look at vital signs in the field, in the helicopter, in the ED, and not simply admission vital signs, because that snapshot was actually misleading in some of the patients. And what we found was the patients, again, these are admitted for observation. You would expect them to be stable. What we found is they fell into 3 groups actually based on hemodynamics. One group, the patients were hemodynamically stable through the entire post-injury course. There was a group of responders who had a little bit of fluid and then stabilized their blood pressure. And then a third group, again admitted for observation, were hemodynamically unstable, and despite that, admitted for observation. And you see that the breakdown is 44% of patients were always stable, a third were responders, and then 25% were admitted for observation despite being hemodynamically unstable. How these patients declare when they fail non-operative management is shown here, and you see the most common reason for patients with blunt splenic injury to fail non-operative management is declining crit or more abdominal pain, but importantly, 15% of patients will acutely decompensate, and the need to have immediate OR availability, immediate surgeon availability to get those patients right to the operating room. This shows mortality and injury severity score in these groups. Again, stable patients, responders, and unstable patients. The injury severity scores were not significantly different between those groups. Despite that, the mortality was 3% in the stable group, 9% in the responders, and 39% in the unstable groups with similar injuries. So obviously, we did something wrong with how we managed those patients. And that's shown here. So of the 97 patients who failed non-operative management, 12 died, and 60% of those deaths were preventable deaths. And 3 of the patients exsanguinated in the trauma center, 2 of whom never made it to the operating room. And the factors in these deaths were, again, unstable patients being admitted for observation with predictable failure. Of the patients who had ultrasound, 42% of FASTs were false negative studies, and then the CT scan studies were often misread. So again, it's a problem when we have a treatment, non-operative management, which is many times more lethal than the disease we're trying to prevent, which is OPSI. So how we manage patients with blunt splenic injury non-operatively is not safe in how we practice it today. And it violates this key principle that no patient should ever die from a splenic injury because we're trying to manage them non-operatively. It's just not acceptable. So what did we learn from the EAST studies? That you need to look at the entire spectrum of vital signs to declare somebody stable, that the FAST can mislead you if negative, and that we've pushed the envelope a little bit too far as who we're willing to manage non-operatively. And what I want to focus on over the next couple minutes is the high-grade injuries, the uncommon grade 4 and 5 splenic injury. This is a study from the National Trauma Data Bank, 6 years, 23,000 adults with blunt splenic injury, and again, 3,000 grade 4 and 5 injuries. And despite what we've talked about, non-operative management was attempted in 40% of the grade 4 and 5 injuries. And it failed in 55% of the patients. So in our trauma centers in the US, if you try to treat a grade 4 and 5 injury non-operatively, it's going to fail more than half the time. This is a similar study using the National Trauma Data Bank, actually about the same time period, but the conclusions from the paper were very different. And the author said that at least 80% of blunt splenic injury can be managed successfully non-operatively, and the patient should be managed and monitored from 3 to 5 days post-injury. That's not what the data says in this paper, actually. And if you look at the success in non-operative management by grade, you see, again, highly successful for grade 1 and 2, not so much for grade 3, and they grouped grade 4 and 5, and again, there's a 50% failure rate in non-operative management of grade 4 and 5 injuries. This is a paper from Dr. Rodriguez, again, our godfather from when he was at Allegheny General, 7 years, 500 patients with an 18% failure rate. Again, you see how uncommon the grade 4 and 5 injuries are, only 5% grade 5 and 12% grade 4. And again, high success rate of non-operative management for grade 1, 2, and 3 injuries, less than half for grade 4, and only 20% for grade 5. So amazingly consistent data in how often the grade 5 injuries fail non-operative management. There is a paper coming out this year that looks at a meta-analysis of all these papers, and the factors that predict failure of non-operative management are high-grade splenic injuries, high injury severity score, and in their review age. So these are the facts as we currently understand them. So I think what the East guidelines actually should say, being a little bit more precise and more helpful to us, is that non-operative management in the hemodynamically stable patient is likely to be successful for grade 1, 2, and 3 injuries. I think we can safely make that statement. And again, that's 80% of the blunt splenic injuries are grade 1, 2, and 3. But grade 4 and 5 injuries are different, and we should have different recommendations. So the grade 4 and 5 injuries greater than 50% still require operation, and the failure rate is greater than 50% if you do attempt to manage these patients non-operatively. And the difficulty with that, based on our study and actually several others, is patients will die as a consequence of non-operative management. So I think to recommend a trial of observation when you know some of the patients will die from that, that makes no sense. It's not safe. So let's talk about angioembolization and the current state of the art. So the East guidelines recommend level 3 data that angiography may be used either as an adjunct to non-operative management for patients who are at high risk for delayed bleeding, or to investigate the vascular anomalies such as active extravasation or pseudoaneurysms. That's fairly vague and not as helpful as it might be. The Western trauma guidelines say that there's considerable variability in the use of angiography, although more aggressive use does seem to increase the success rate of non-operative management and the lowest failure rates. There's ongoing debate about the optimal use of angioembolization. And again, this is the guidelines from the Western Trauma Association. So I don't find these terribly helpful. They're a little bit too vague. So the question is, are there better guidelines that we can glean from the literature? This is a nice paper from last year, a meta-analysis looking at the role of angiography embolization, 33 articles, 10,000 patients, and again, 31% of adults with blunt splenic injury go to the OR, 69% managed non-operatively, grade 4 and 5 injuries managed non-operatively were, again, uncommon. And you see 80% of grade 5 injuries went directly to the OR and 44% of grade 4 injuries. So again, that theme continues. And what they did was compare the failure rate of patients who were simply observed to the failure rate of patients who underwent angioembolization. So instead of lumping them together, which commonly happens, they looked at them as two distinct groups. And in the patients who were simply observed, meaning no angioembolization, you see almost identical to the East data, the failure rate of non-operative management goes up to a prohibitively high level for grade 4 and grade 5 injuries. But if you look at patients managed non-operatively with angioembolization, that high failure rate for grade 4 and 5 injuries goes away. So angioembolization in this review, the meta-analysis, takes away that high failure rate in the grade 4 and 5 injuries. This is a paper out of the University of Florida that looked at 10 years of data, over 1,000 patients with blunt splenic injury, and what they did was look at their current schema. So they sorted it down to 847 adults, 36% went directly to the OR, and then they looked at the patients managed non-operatively, similar to the last study, those who underwent no angioembolization and those that underwent angioembolization. And interestingly, the failure rate in those large groups was identical. It was 4% in both groups. But if you break it down by grade, then you end up with very different data. Now, the other interesting thing is if you look at the clinical variables by treatment group, operation, non-operative management, no angioembolization, non-operative management with angioembolization, the injury severity score and blood pressure, again, is identical to that East paper I showed you. So I think what angioembolization does is take away that high-risk failure group that we talked about in the East studies. And they looked at failure rate in the patients who were observed only, and again, you see it goes to a prohibitively high level for the grade 5 injuries, but angioembolization, again, for grade 4 and 5 injuries, eliminates that high failure rate. So it has a definite role with those patients. So what is the current role of angioembolization in the adult patient with blunt splenic injury? So in a stable patient, I think where it's useful is active extravasation on CT scan, splenic artery pseudoaneurysm, or the grade 4 and 5 injury in a patient where you know the failure rate will be prohibitively high. And there's a paper coming out that shows that even if you don't see a blush on angiography for the grade 4 and 5 injuries, you should embolize that spleen so it doesn't fail later. So what is the state of the art right now with blunt splenic injury? So 20 to 30% of adults with splenic injury are unstable and require immediate operation. Only hemodynamically stable patients should be considered for observation. 80% of splenic injuries are grade 1 to 3, and those patients do well with observation. 12 to 20% of splenic injuries are grade 4 and 5, and at least 50% of those still need to go to the operating room. And the failure rate of observation alone for grade 4 and 5 injuries is unacceptably high, greater than 50%. Angiography decreases bleeding in the presence of active extravasation, vascular blush, or pseudoaneurysm. And the use of angiography and embolization in a stable patient with a grade 4 or 5 splenic injury decreases the failure rate in this group. And again, even with a negative arteriogram with a grade 4 and 5 injury, I suggest that you should consider embolizing those patients. So again, thank you for the opportunity to give this talk, and I appreciate your attention. Muchas gracias.